Hi, I'm Andy Cheetham, Nuclear Medicine Technologist and Clinical Tutor at King's College Hospital. I'd like to talk to you today about the design and testing of a positioning device for use during SPECT CT imaging of the feet. For your information, there is a financial declaration of interest here. As you know, a bone SPECT CT may be used to evaluate a number of clinical conditions involving the feet. However, the usefulness of the test may be impaired by such things as patient motion, misregistration of the nuclear medicine and CT data, and poor orientation of the images. Back in 1992, in the days of axial CT scanning, various positions were recommended for imaging of the feet. Nowadays, CT scanning is still undertaken with the foot placed upright in the field of view, such that the plantar surface is parallel to the scanner's transaxial plane. Holding such a position for 20 minutes required for a SPECT CT study may, however, be quite difficult. The images will be degraded if the patient moves during the study, and may also lead to misregistration between the SPECT and CT images. Here you can see a small amount of motion in the toes has led to the misregistration. Our previous setup involved using a wedge cushion and straps to hold the feet together, although the feet are usually then extended and they are often twisted. Here you can see from a sagittal view that the foot is twisted. So for instance, we have 3 metatarsals all in the same sagittal slice. Of course, we can reorientate the images. The green line in the bottom left-hand corner is the transaxial plane. We can rotate this through the long axis of the foot. As we rotate it, we can see the effect in the upper right-hand corner. We can now see that we have a transaxial view through the feet. However, if we rotate a little further to better view the metatarsals, we suddenly see the feet turn upside down. What's happened here? The patient wasn't laying prone. Are the left and the right images swapped? I don't think so. If that's not happening, what is? Has the slice order changed? I'm not sure. Now, if I don't know what is happening, then it isn't fair to present these images to someone else for reporting. How are they going to find out what the correct views are? Maybe it would be better if we started with the patient positioned in the ideal position rather than trying to solve the problem after acquisition. We therefore designed a positioning device to be used during SPECT CT. The device should have a central bar and backplate to hold the feet in the upright position. Heel dips guide the feet into the correct position, and straps hold the feet in place. The device needs to be CT compatible as well as cleanable. Cutaway corners allow the gamma camera to come in close during the SPECT orbit. Bright Technologies Ltd took our specifications and built a prototype device for us. Here you can see it in use. Note how it replicates the position recommended for CT imaging of the feet. To test the device, we looked at 20 patients, 10 with and 10 without the foot immobilizer. Images were analysed for patient motion, misregistration of the SPECT and CT data, as well as orientation of the feet. To determine the position of the feet, we first defined the long axis as a line bisecting the third metatarsal and the posterior aspect of the talar calcaneal joint. Flexion of the foot was then the angle of this line to the transaxial plane of the scanner. Using the same long axis, the rotation of the foot is defined as the angle of the long axis relative to the sagittal plane. In this case, the foot is almost vertical. We can see that the use of the immobilisation device reduces the number of studies with motion or misregistration artifacts. The device also reduces the flexion of the foot. Using the device, the foot is much closer to the upright position, although it has little effect on the rotation of the foot. Let us consider the immobiliser in use. Here we have the case of a 50-year-old patient suffering from sudden onset of pain in the posterior heel and ankle. The MRI stir image shows edema in the posterior aspect of the calcaneum. The fused images show osteoblastic uptake at the insertion of the Achilles tendon, and also uptake associated with an osteophyte at the posterior aspect of the talus. However, rather than concentrating on the clinical results, what I would like you to note is the almost identical positioning of the foot between the two studies. Looking now at the transaxial view, we can see an almost perfect alignment between the two modalities. The use of the foot immobiliser has allowed us to produce images that are almost identical in positioning. This orientation obviously allows easier reporting. It can thus be seen that the use of the immobilisation device improves image quality by reducing patient motion, misregistration of the SPECT and CT data, and improved orientation of the images. That is to say, if you use the device, you can get high quality SPECT CT images like this. I would like to thank my co-authors, including Stephen Anderson from Bright Technologies Ltd, and also a big thank you to you for listening.